Good afternoon, and thank you for joining us today for the CPH exam review webinar. Today, we're going to be going over evidence-based public health. Today, we'll not be going over biostatistics. We are going to be focused on evidence-based public health. There is one of the various resources we have for a study for the CPH exam, and I want to take a moment and go over a few of the other study resources we have with you so that you'll know the different tools you have in your dashboard as you prepare for the exam. There are a number of items that you can review. We recommend that people that are looking to start studying for the exam go and review the content outline on the NBPHE website. That's going to go over the different things that are included on the exam. It's going to go over the 10 different areas, and it's going to talk about each of the areas that are represented on the exam. And as you can see, everything is equally weighted on the exam. You have evidence-based approaches to public health, communication, leadership, law and ethics, public health biology and human disease risk, collaboration and partnership, program planning and evaluation, program management, and policy and public health, as well as health equity and social justice. Now, you can review this guidelines and kind of get a feel for where you need to focus your studying. The next study resource we have is some sample exam questions, and this is going to be free on the NBPHE website. And these questions are intended to give you a preview of the format of the questions so you can get an idea of what type of questions you will be faced with on the exam. All the questions are single best answer. They are straightforward. There is no fill in the blank, and there are no calculations on the exam. Next, we suggest that you take a practice exam, and there is an online exam of 50 questions from the CPH item bank. These are not live questions, but retired questions from an actual exam. This is a static selection of questions, so you won't see different questions when you take this exam, but it will give you an idea of the flow of the actual exam. You will receive a detailed report with the results, and it's an excellent way for you to determine how prepared you feel like you are ready to take the exam. And then we also have additional webinars on each domain and Q&A. Next up on August 7th, we have Health Equity, Social Justice, and the Application of Theory. August 14th, Planning and Evaluation, Collaboration and Partnerships. August 28th, Public Health Systems, History and Leadership. September 10th, we have Public Health Law. September 17th, Health Policy Process. And on the 27th, Public Health Biology and Human Disease Risk. And then we also are adding a biostatistics webinar, which will be coming up in the fall. And we will post all of these on the NBPHE website, as well as you can view archived webinars and PowerPoint presentations from previous webinars. And then we also do have a CPH study guide at aspph.org. And this is something that ASPPH has created. We have over 370 questions that were developed by item writers that reflect the kind of content you will see on the exam. And this is an interactive study guide. It's going to go through different sample questions. And then once you go through that, it'll have a detailed explanation for each of the questions, as well as resources you can click on for further information. And some of the questions will have a videoed response from a presenter expert in public health. And then we also do recommend an APHA Press study guide. This was written by several of the presenters that you will hear on these webinars. It was written by our faculty at South Florida College of Public Health, and they are intricate, critical with the development of these different study materials. They know the ins and outs of the types of questions and the content developed and that you will see on the exam, and we highly recommend this book. You can also go to APHA Press if you're interested in buying it. It's $41.95 for APHA members and $51.95 for non-members. Now I'm excited to go ahead and get started today. Today we do have two of those faculty that were authors in that CPH exam review, Ronnie Wilson and Janice Zigber. Both are faculty members at the University of South Florida College of Public Health, and I'm delighted to turn the presentation over to them. Now, a few housekeeping items. There is if you click on the orange arrow in your control, you will see that you do have a questions box that you can insert questions in. I will be monitoring this as we go along. If there's any general questions, I'll answer them as we go. And then our two presenters at the end of their prepared materials, they will answer questions as time permits. If there are any questions that have not been answered, we will have everyone's email address, and the presenters will answer questions and send everyone a comprehensive Q&A response after that. So my pleasure to turn the presentation over to Dr. Wilson and Dr. Ziegber. Ladies.
Thank you, Erin. Hello, everyone, and thank you for joining us today. I am Ronée Wilson. I'm an assistant professor of epidemiology at the University of South Florida, College of Public Health, and I will be covering the first half of this presentation today. Oh. Okay. Sorry, there's a delay on my end with the slide advance. So the objectives for today's presentation, at least for the first half, are to define and calculate measures of association in epidemiology, to distinguish incidence, prevalence, cumulative incidence, and incidence rates, and to enumerate the most common study designs used in epidemiologic research. And as Erin mentioned in the introduction, we won't be covering biostatistics today, but there will be an additional webinar at a later date on biostatistics, as well as those archived biostatistics lectures that are available on the National Board of Public Health Examiners website. So what is epidemiology? I'm still fighting with these slides. It's the study of the distribution and determinants of health-related states and events in specified populations, such as neighborhoods, schools, cities, etc. So let's break down a couple of these terms. Distribution refers to the frequency or pattern of events, and determinants relates to the causes or risk factors of events. A risk factor being a behavior, an environmental exposure, or a human characteristic that is associated with a health-related condition. And if you'll notice, I'm saying events because epidemiology is not just the study of disease. We study many different health outcomes. So what is the role of epidemiology in public health? One is to monitor health of a population, to respond to emerging public health problems, Erin, you might have to advance on your end. Is that okay?
Yes, I can take over. I'm sorry about the delay.
That's okay. If you could take over, I think yours might be a little quicker than mine. I'll just say next slide if that's all right.
Perfect.
Okay, so the role of epidemiology in public health is to, one, monitor health of a population, to respond to emerging public health problems, to promote research and the use of evidence-based interventions, to evaluate the effectiveness of these interventions, and also to provide foundations for public health policy, in addition to setting funding priorities for research and intervention programs. Next slide, please. Okay, so we've come to our first checkpoint. To make sure you're all still with us, we have integrated a few poll questions throughout the presentation. I will read this first question and ask you all to respond using our polling system. So the question is, which component of epidemiology describes who gets the disease, where people with the disease are located, and how these aspects of disease change over time? Is that determinants, distribution, frequency, or control. And we'll give you a few minutes to give us your response, or a minute. Okay? Okay, so we have about 35% who said determinants, the majority said distribution, a few said frequency, and no votes for control. The correct answer is distribution, so that's great. The majority of the folks picked distribution. If you missed that, go back and look over the definition of epidemiology. All right, next slide. Next, we'll talk about measures of association. Next slide, please. So before we get into the different types of measures of association that are most common in epidemiology, and since much of public health focuses on specific populations, let's make sure we're all working from the same definition of population. So here we have population defined as a group of people with a common characteristic in terms of person, place, and time. So for example, this could be related to age, could be related to sex or gender, race, ethnicity, etc. So within the definition of population, you may also see definitions of a fixed population versus a transient or dynamic population. So a fixed population is membership based on an event that is permanent. So for example, all babies born in Tampa in 2018, that would be a permanent or a fixed population. A transient or dynamic population is comprised of membership based on a condition that can change. For example, students of a particular university or members of a gym. Next slide, please. So here we have some common terms that we use in epidemiology. So we have mortality, which is an epidemiologic term for death. And some measures that usually fall under mortality are crude mortality, which is the number of deaths from all causes. Also age-specific mortality, which is the number of deaths from all causes in a specific age group. Cause-specific mortality is just as it sounds, the number of deaths from a specific cause. And then infant mortality is the number of deaths of infants less than 1 year of age. Another common epidemiologic term is morbidity. This is the term that we typically use to describe disease. So prevalence rate, which we'll talk more about later, is the number of existing cases of disease or morbidity, and incidence rate is the number of new cases of disease or disability. Number of new cases of disease or morbidity. Disability is an umbrella term for impairments, activity limitations, or participation restrictions. Next slide, please. Additional terms that you typically see in epidemiology or when talking about epidemiology is distribution. So distribution, again, describes disease frequency, which is the quantification of mortality, morbidity, and disability in the population. So for example, how often does the MMD occur in the population? Also, disease distribution or the analysis of patterns. So for example, who is getting the MMD? Where is the mortality, morbidity, or disability occurring? And does the number of MMD change over time? Next slide, please. Let's talk about the emics. So epidemic, endemic, pandemic. So most of you have heard of epidemic, which is the outbreak or occurrence of a death, disease, or disability from a single source in a group, population, community, or geographical area area in excess of what we would typically see, so more than what we're used to seeing. Endemic is the ongoing or usual level of or constant presence of death, disease, or disability within a given population or geographic area. And pandemic is an epidemic that is widespread across a country, continent, or a large populace, so possibly worldwide, such as HIV/AIDS. HIV/AIDS extends beyond one continent. It actually covers multiple continents. Next slide, please. All right, now on to the primary measures of association. So the primary objective of measures of association in epidemiology is to relate the number of cases of disease or health events to the size of the population and at the timing or the occurrence of these diseases. So ratio is one number over another, or the division of one number by another. The numbers don't have to be related. For example, we may want to look at the ratio of men to women in terms of a particular outcome. A proportion is often expressed as a percentage, and the number and the numerator or the top number is a subset of the denominator or the bottom number. For example, we may want to know what proportion of people are participating in the webinar from the comforts of their own home, or what proportion or percentage of people participating on this webinar have already planned their next vacation. A rate is also one number divided by a number, but time is incorporated into the denominator. So one rate that most people are familiar with is miles per hour. That's a common rate that we use every day. A commonly used rate in epidemiology is the mortality rate, or the proportion of deaths occurring over a span of time in a population. Next slide, please. On to prevalence. So again, prevalence is the number of existing cases of disease over the number in the total population. If we're looking at it at a particular point in time, that would be point prevalence. And we'll talk a little bit more about that later. So for example, City A has 7,000 people with arthritis on January 1, 2009. The population of City A is 70,000. Therefore, the prevalence of arthritis on January 1 of that year would be calculated using 7,000 over 70,000, which gives us 10%. So in this hypothetical scenario, approximately 10% of the population has arthritis. Next slide, please. Incidence is defined as the number of new cases of disease or health event that develops in a population at risk during a specified time period. There are three key concepts when talking about incidence. One, it must be a new disease event, or for diseases that can occur more than once, we often just use the first occurrence of the disease. Again, the population must be at risk for the particular condition of interest, meaning they can't already have the disease and they should have the relevant organs. So for example, we would not calculate incidence of prostate cancer with women in the numerator or the denominator because women don't have a prostate. And time is an important component. So time must pass for a person to move from health to disease. There are two types of incidence measures that we're going to cover: cumulative incidence and incidence rate. Next slide, please. Cumulative incidence is the number of new cases of disease, which will be the numerator, the number in the candidate population over a specified period of time, which would be the denominator. So cumulative incidence estimates the probability or the risk that a person will develop disease during a specified time. Note that the candidate population is comprised of people who are at risk of getting the disease. So again, these cannot be individuals who already have it or are not at risk to get it. It's used mainly for fixed populations because it assumes that everyone is followed for the entire time period. Next slide, please. Incidence rate is the number of new cases of disease in a candidate population divided by person time of observation. This measure is a true rate because it directly integrates time into the denominator. The next slide will give you an example of how we calculate incidence rate. Next slide, please. So here we have a hypothetical example of 5 individuals. So if you look at line A, you see a person who contributes 4 person years to our population or to our study. The person comes into our study at 2001, and in 2005, they're diagnosed with the disease. So again, that's 4 years that they contribute. Person B comes into our study right at the beginning in 2000, and they die in 2006, so they contribute 6 years, so on and so forth. So let's look at person E. Person E comes in 2003, and then they're there for the completion of the study, which is 2010, and so they contribute 7 years. That's how we calculate person years. We calculate the time that each individual contributes to our study. Next slide, please. So the relationship between incidence and prevalence is also related to the duration of the disease. So the first thing we have to remember is that the incidence decreases. If the incidence decreases but people are living longer with the disease, that means our prevalence will decrease. Our prevalence will increase. If the incidence increases but the duration is short, that means our prevalence will decrease. If the incidence decreases and the duration is short, the prevalence decreases. I have a diagram on the next page that should help seal this. Okay, so here we have this bathtub with a faucet, which represents our new cases that are entering our tub, and our tub represents our prevalence. So at the bottom of the tub, you see this hole where people are either dying or being cured, but they're leaving the tub or they're leaving the pool. You may have some conditions where people are reinfected and they may enter into the tub again. But what you'll notice here is that if you have a greater number of new cases, then that can increase your prevalence. Unless, of course, your hole is really big and people are draining out of this tub very quickly, then that also impacts your prevalence. So that's how the relationship between incidence and prevalence works. If you have more cases coming in, then that could increase your prevalence. But if you have a lot of cases going out, then if they're going out faster than they're coming in, that decreases your prevalence. Okay, thanks. Next slide, please. All right, we've come to our next checkpoint. Which of the following is calculated by dividing the number of new cases of disease by the total population at risk? Cumulative incidence, incidence density, point prevalence, or prevalence rate? Okay. Let's see what everybody said. So we have about 50% of folks voting for cumulative incidence, 30% for incidence density, some for this very creative spelling of point prevalence, and about 18% for prevalence rate. So about half of you got it right, and the answer is cumulative incidence. All right, let's go on to odds ratio. and relative risk. Next slide. Okay, so here we have your standard 2x2 table. So for those of you who may not have seen a 2x2 table in a while, let's orient ourselves to what we're looking at. So across the top, we have disease, no disease. And then going down the sides, we have exposed, unexposed. This is the way we typically set up our 2x2 tables. So if you look at cell A, these are individuals who are exposed and also have the disease. Look across to cell B. You have people who are exposed but did not develop the disease. And then all the way across in that row, we have A plus B, which equals all individuals who are exposed regardless of their disease status. Going down to the next row for unexposed, C are all those individuals who are unexposed to our exposure of interest but still have our disease of interest. And D is all of those individuals who were unexposed to our exposure of interest and do not have our disease of interest either. And then again, C plus D equals all individuals who are unexposed regardless of their disease status. And A plus B plus C plus D is everyone in our study or everyone in the 2x2 table. Okay, next. So when we're trying to calculate a relative risk using our 2x2 table, we're going to take everyone who was exposed and has the disease, so that's cell A, and we're going to calculate the rate of exposure by dividing A over everyone who was exposed, so A plus B. Additionally, for our denominator, we're going to take C and divide it by C plus D to get the rate in unexposed. Using the rate in the exposed and the rate in the unexposed, this is how we calculate our relative risk. Next slide, please, and I'll have an example for you. Oh, interpretations first. So first, let's interpret our relative risk. So if we have an RR of 1, that means there's no association between exposure and disease. Because if our rate in an exposed equals our rate in the unexposed, then we don't see an association or a relationship. However, if we have an RR of 2, for example, that means that 2 times the risk of disease, there's 2 times the risk of disease in the exposed compared to the unexposed. If we have an RR, for example, of 1.6, we would say there's 1.6 times the risk of disease in the exposed compared to the unexposed, or we could also say that there's a 60% increased risk of disease in the exposed. If we have an RR that's less than 1, so for example, an RR of 0.5 times, we'd say that there's half the risk of disease in exposed compared to unexposed. So in that case, it'd be better to be unexposed than exposed. All right, next slide. Here's our example. So this is a cohort study of hypertension and cardiovascular morbidity and mortality using Nurses Health Study data. Our 2x2 table here has hypertension as our exposure of interest down the side, so hypertension, yes or no. And then non-fatal heart attack is our outcome of interest across the top, yes or no. So we have 117 individuals who had hypertension and also experienced a non-fatal heart attack. And we had 106,416 that did not have hypertension and did not have a heart attack. And the total people in the sample was 119,963. Okay, just pointing out some numbers so that I can orient you to the table. Could you click one more time, Erin? Thanks. Okay, so calculating our RR, again, we're going to calculate the cumulative incidence in the exposed, and we're going to divide it by the cumulative incidence in the unexposed. So we're going to take that 117 from A and divide it by A plus B, which is that 13,422. And then we're going to take C, the 125, divide it by the 106, 541, which is C plus D, and that's going to give us 7.5. One more click. So the interpretation of this is that women with hypertension have 7.5 times the risk of having a non-fatal heart attack compared to women without hypertension. So that's an example of how we would calculate RR from a 2x2 table. Next slide, please. Okay, so let's move on to odds ratio. The odds ratio represents the odds that an outcome will occur given a particular exposure, compared to the odds of the outcome occurring in the absence of that exposure. So the odds ratio is most commonly used in case control studies, but they can be used in cross-sectional or cohort studies as well. Next slide. Okay, we have another 2x2 table. Again, disease across the top, exposure down the side. So same setup, but to calculate our OR, we're going to do what we call our cross products. So we're going to multiply A times D and divide it by B times C. So that's why we have the calculation or the equation OR equals AD over BC. So for those of you who've ever taken epidemiology classes, you should know that equation very well. Okay, next slide. So here's our next checkpoint. Which condition must be met in order for the odds ratio to approximate the relative risk? Is it that the disease must be common, the disease must be rare, the exposure must be common, or the exposure must be rare? All right. Let's see what we got. Okay. So we have about 19% of people said the disease must be common, 28% the disease must be rare, 42% the exposure must be common, and 11% the exposure must be rare. So the correct answer to this is that the disease must be rare. And this is basically a mathematical question. So if the disease is rare, then A plus B will approximate B, and C plus D will approximate D. And if you do some great algebra, you will see that your OR will approximate your RR. So for those of you who are not familiar with this concept, make sure you go back and review this in any material that you can find on the National Board of Public Health Examiners website. Next slide, please. All right, we're going to get into study design for epidemiologic studies. Next slide. Here we have the evidence-based pyramid. So for those of you who are not familiar with this photograph, here we have, over on the left side, TRIP database searches. TRIP is essentially turning research into practice. It's just an example of a clinical search engine, but you could use PubMed, you could use any other search engine that you're familiar with. But on the right side, you'll see filtered information and unfiltered information. So systematic reviews, meta-analyses, critically appraised literature have all gone through an evaluation process, which is why we call them filtered. For any information that has not been critically appraised or reviewed, it's considered unfiltered. So starting at the bottom of this pyramid and moving up, going from expert opinion to randomized controlled trial, this follows the direction of the level of evidence we have about particular health topics, with the randomized controlled trial considered as the gold standard for epidemiologic studies. Next slide, please. Okay, we're back to our populations. Let's talk a little bit more about these. A couple clicks for me, Erin. So first, we have our target population, which is the outside ring, and it represents the general population that we seek to understand with our study. Our next ring is our source population, which includes the specific individuals from which we want to draw a representative sample for our study. The eligible population or the sample population are individuals who actually meet the eligibility criteria and are invited to participate in our study. And then the study population is just as it sounds, those individuals who actually participate in our study. Okay, next slide, please. The ecological study, or the correlational study, a couple clicks, sorry, is the first study design we're going to talk about. The unit of analysis for this study is the population as a whole or the group as a whole. And the exposure status, again, is based on the population as a whole versus some of the other study designs that we're going to talk about later where we have individual level data. So for the ecological study, the time under study can vary. One of the things that you'll hear a lot with the ecological study is the ecological fallacy, which means making assumptions about individuals based on findings at the population level. If you go to the next slide, there's an example that might clear this up a little bit. So down the side, we see that we're looking at age-adjusted prostate cancer mortality rates. And across the bottom, you'll see the per capita sugar consumption. So essentially, this figure is a diagram of prostate cancer mortality compared to sugar consumption in 71 countries. So again, this is not a diagram of individual level data. This is looking at population-based data for 71 countries. So that they've taken the mortality rates for mortality for 71 countries and compared it to the per capita sugar consumption for those same 71 countries to see if there's a relationship between sugar consumption and mortality. And that's an ecological study. Next slide, please. So for a cross-sectional study, this is considered a snapshot in time. If a particular point in time, then we'd be looking at point prevalence of a particular health condition or outcome. With the cross-sectional study, typically we are looking at information on an individual level. So for instance, a cross-sectional study could be a survey. Maybe you're doing a survey at the mall, and so you're handing out these surveys to individuals who are walking through the mall. The population is selected without regard to exposure or disease status. The primary measure that we get from a cross-sectional study is prevalence of disease. If we want to try to calculate a measure of association, we would use the OR. One of the drawbacks with a cross-sectional study is that we cannot determine which came first, the exposure or the disease, because we're collecting information on both of those things at the same time. So we cannot determine cause or effect with a cross-sectional study. Next slide, please. This is a diagram of studies. So starting at the top, did the investigator assign exposures? The answer is no. Then we're looking at an observational study. Are we testing a hypothesis? If the answer is no. We would be looking at a descriptive study. If the answer is yes, we're looking at an analytical study. If the sampling is based on neither exposure or outcome, then we have a cross-sectional study. Next. So for example, we have a study that compares the prevalence of high blood pressure among current Massachusetts Turnpike toll booth collectors with the current prevalence of high blood pressure of current Turnpike office workers. That would be an example of a cross-sectional study. So now moving on to case control studies. Case control studies are good if the disease is rare, if it has a long induction or latent period, if little is known about the disease, and if we're selecting our cases and we're selecting our controls. So let's go again to our diagram. So again, did the investigator assign exposures? If the answer is no, it's an observational study. Are we testing a hypothesis? Typically in a case control study you are, so the answer would be yes, and it's an analytical study. And typically for a case control study, you are sampling based on whether or not individuals have your outcome of interest. And so we have a case control study. Next slide, please. This is another graphical representation of a case control study. So we have exposure, yes or no. We have whether or not, so essentially we recruit our individuals based on whether or not they have the condition of interest, and then we look back to see if they had our exposure of interest. So those would be our cases. For our controls, which is this purple box at the bottom, those are individuals in the population without our outcome of interest, and then we also ask them about their exposure. So whether they had our exposure, yes or no. And that's the basic setup of a case control study. You have your cases, your individuals with disease. You determine whether or not they have your exposure of interest. You have your controls, your individuals without disease, and you determine whether or not they have your exposure of interest. Next slide. Now we're on to our cohort study. So let's look at our chart again. With the cohort study, the investigator is not going to assign exposures. So we're taking the path of no. We are typically going to test a hypothesis with a cohort study. And with the cohort study, we are recruiting our individuals based on whether or not they have our exposure of interest. And typically with a cohort study, we follow people to determine whether or not they develop our condition or disease of interest. Next slide, please. So the formal definition of a cohort study is a study in which two or more groups of people who are free of disease and that differ according to the extent of exposures are compared with respect to whether or not they develop our disease of interest. So cohort studies are the observational equivalent of experimental studies, but in this case, the researchers cannot allocate exposure. Next slide, please. So the purpose of a cohort study is to study causes of diseases or health outcomes, to look at different types of preventions and possibly treatments for diseases. Key features of the cohort study: the investigator selects subjects according to their level of exposure and follows them to see whether or not they develop the disease or outcome of interest. They're typically done if a randomized control trial is not feasible, or if it's not ethical or would be too expensive. And also if moderate or large effects are expected. If there's little known about the exposure, a cohort study is also a good design so that we can follow individuals forward and find out more about it. Also, it allows us to evaluate different effects of a particular exposure. It also is a good study design if the exposure that we're interested in is rare. Next slide, please. Okay, now Dr. Skipper is up next, and she's going to cover randomized controlled trials.
Good afternoon, everyone. I'm Dr. Janice Skibber. I'm a professor of epidemiology at the USF College of Public Health, and I'll be presenting some study design, some study measurement terminology, as well as diagnostic testing. Next slide, please. So the randomized controlled trial, when we look at the figure, kind of reorienting ourselves starting at the top, in this case, the investigator does assign an exposure. And until now, the answer was no to that question. But as we answer yes, we're looking at the left side of the figure at the experimental study. There can be two types, either randomized or non-randomized, but today we'll focus on the randomized controlled trial. Next slide. The randomized controlled trial, or RCT, investigates the role of some agent in the prevention or treatment of disease. And that agent can be a treatment, a screening program, or an intervention. The investigator controls the agent in the realm that they administer it or not. And it's because of this control that the RCT is considered the gold standard. Next slide. The overall conduct of a clinical trial follows this general order. The hypothesis is formed. The study subjects are recruited based on specific inclusion and exclusion criteria, and their informed consent is obtained. The subjects are randomly allocated to receive one of the two or more interventions being compared, and study groups are monitored for outcomes under study. And that can be recurrence of disease, first occurrence of disease, getting better, the side effects, whatever the outcome of interest is. And then rates of the outcome in the groups are compared to see if there are differences. So I mentioned that people are randomized into a treatment or control type group or usual care. So we randomize, next slide, to achieve baseline comparability between the groups on factors related to the outcome. So ideally, compared groups are the same except for the treatment of interest. So randomization provides a balance between the groups with respect to what is known and what is unknown. The larger the groups, the better the randomization works. Next slide. So we're going to revisit this population slide again as it pertains to the randomized controlled trial. So when we look at the target population, the goal in randomized controlled trials is to be able to say something about the population that we're interested in. In other words, the population to which we want to generalize. So for example, our target population may be postmenopausal women. The source population is the population from which we'll draw our sample. And in our example, this may be postmenopausal women from the state of Florida. Then we may further define the sample, defining who is eligible for the study. Eligibility is defined by inclusion and exclusion criteria. Following our example, this may be postmenopausal women from the state of Florida with a BMI greater than 30, diagnosed with hypertension. And then finally, you'll have your eligible population or your study population, which will include those women who consent to be in your clinical trial, and that is your final study population. Next slide. One of the challenges in conducting clinical trials is retaining participants once you recruit them, and it's particularly challenging in longer clinical trials. So in order for us to have valid results from a randomized controlled trial, the participants need to remain active and provide data for us to analyze. So as you're designing a study, it's important to think about why would participants drop out of a study. So one of the things to think about is what is the burden of the trial? What is the burden of the intervention on the participants? And you want to keep that as minimal as possible by looking at the feasibility of the intervention, the support of the intervention, commitment to the objectives of the study, and you can retain participants through many things, incentives being one of them. So perhaps you can incentivize participants by a small monetary incentive, or sometimes it can be something that is of a small value to the study or related to the study that will keep participants engaged in the study for a longer period of time. One of the other problems in clinical trials is that you may have dropouts of the study that are unequal in each group. And that can bring up problems analytically. While we can deal with it in advanced methods, ideally you want to keep the groups as similar as possible in number. And the strategies for increasing compliance in a randomized controlled trial are considered in the design phase by looking at the intervention and the burden of the intervention, the questionnaires, all of the things that you need to do to measure things, and what you can do throughout the study to keep participants engaged. Next slide. Another factor of randomized controlled trials that is unique is using placebos or blinding. So placebos are used to make the groups as comparable as possible. So most often we think of placebos in drug trials, where The placebo tablet looks identical to the actual active ingredient tablet, and so that participants are blinded to what group they're in. Also, the investigators may be blinded to whether the participants are in the placebo or the active treatment arm. So when you're blinding, the subjects may not know if they're receiving treatment or placebo, which is a single blind study. If neither the subjects nor investigators know who is receiving treatment or placebo, that's considered a double blind study. And the purpose of blinding is to avoid bias and ascertaining the outcome. So it's best if the investigators, wherever possible, don't know what group the participants are in, so they aren't more avidly looking for side effects or more avidly looking to ascertain the outcome. They're looking at all of the participants with the same mindset. So the placebo allows the study to be blinded so that the investigators and patients don't know which arm they're in. Next slide. Another critical factor, back up one, in the clinical trial is ascertaining the outcome. So I mentioned retention. So one of the goals to ascertain good outcome data is to have high follow-up rates. We don't want to lose people, we want to retain them. We also want to have uniform follow-up throughout all the groups and be equally vigilant in all of the follow-up in the groups. If we don't have that uniform ascertainment, then your study is at risk of bias. And we'll get into those definitions a little bit later, but just keep that word bias in mind. Next slide. So when we're looking at analysis of data from experimental studies, the initial analysis consists of the familiar 2x2 table. Because clinical trials are conducted prospectively, the measure of association is the relative risk. So the investigator will compare the impact of the treatment or intervention among people who are exposed to the intervention and compare them to people who were unexposed to the intervention. Next slide. So we're moving on to validity, and validity in research is essential so that we know what we're measuring is actually what we want to measure, and we're saying what we expect to be saying about our studies. And there are two types of validity that we consider in the randomized controlled trial, and they're internal and external validity. Internal validity assesses how well the study was conducted. So for example, in all research studies, we take a lot of measurements, and they need to be accurate, and they need to be accurate amongst all participants. So the methods used to measure people must be as rigorous as they can be among all participants. The investigators should be blinded to the intervention, as should the assessors, and everyone should be trained using a standardized protocol. Another aspect of internal validity is the inclusion and exclusion criteria. A rigorously designed and implemented study has high internal validity and usually has a very long list of inclusion and exclusion criteria. External validity assesses how generalizable the results are. So can our results indeed be generalized to the target population or the population we're most interested in? And can the results be replicated under different conditions? In general, the higher the internal validity is, the lower the external validity will be, and vice versa. There's always a trade-off. If you're testing a new treatment for efficacy in a specific population, you need to have high internal validity, but the external validity will be limited as it's only relevant to that specific population that you studied. If you're implementing a well-tested intervention in a community, you will likely have high external validity, but you're giving up some of that rigor in the internal validity. It's always a balancing game when you're doing these types of studies, but it depends on where the research is in the continuum as well. Next slide. So what are some threats to internal validity? And again, that's the rigor with which the study is conducted. So if, internal validity is really important so that the associations we find aren't false or spurious. And it ensures that our conclusions that we make are indeed valid, but the threats to internal validity exist no matter how careful you are, and they can be divided into 3 categories: bias, chance, and confounding. Next slide. So chance is something that merely happens at random. It will happen no matter what we do, but we will decrease the likelihood of this random variation if we increase the sample size. If the sample size is large enough, the likelihood of chance impacting our results is smaller. Bias, however, is an unintended mistake of the researcher, and this really can affect the validity of the study. Sample size will have nothing to do with fixing bias, and it's best to prevent or minimize the chance of bias at the design stage. And being able to deal with it in the analysis phase is also quite difficult. So decreasing the likelihood of bias when the study is designed is most important. Confounding is not a mistake, but it must be controlled. It's also not impacted by sample size, and it can be minimized or controlled for in the design and or the analysis phase of the study. Next slide. We'll get into these in a little more detail. So bias, as I mentioned, is a systematic error in the design or conduct of the study. So the error arises from flaws in either the method of selection of study participants, so that's selection bias. So perhaps you selected study participants in such a way that it really impacts your results by disease status or location or some other factor. Your procedures for the study and gathering exposure or disease information can also impact your results, and that's entitled misclassification bias. So you may identify someone as exposed or unexposed or having the disease or not based on the wrong classification, leading to bias. The effect of bias is significant in that erroneous results will lead to misleading conclusions and therefore the misinformation distribution. Next slide. So when we deal with bias, we need to deal with it at the study design phase. And that is not only good study design, but appropriate subject selection. Couple clicks here. Subject or study personnel blinded to the status, and then training. The people working on the study must undergo standardized training and training renewal and refreshers and so forth to make sure everything is being measured in a standardized way. For data collection, everyone should understand the definitions of your exposures and outcomes, how to do the measurements and what measurements you're using. So if you're measuring blood pressure, for example, are you measuring it all the same way? Are you using the same cuffs? Are you using a standardized protocol? And then finally, quality control in the data collection. Are you making sure the data are collected as you intended? Is there a lot of missing data? Are people not checking the right boxes, or are they writing in answers? So really undergoing good quality control of the data. Next slide. Confounding. Next slide. So confounding is a distortion in the measure of the association between the exposure and outcome. It's a mixing of effects because the association between the exposure and disease is distorted because it's mixed with the effect of another factor that is associated with the disease or outcome. Confounding is a problem of comparison and one that arises when important extraneous factors are differentially distributed across the groups being compared. So often we'll see confounding by sex. So the distribution of disease may be different among men and women and how the outcome is assessed, and there's the sex is the confounding factor because the outcome differs by gender. So here's another example of confounding. Next slide. You compare the effects of new handgun legislation in New York City on total mortality using Miami as the control population who did not have the legislation. So the problem that you've identified is that New York City will have lower total mortality even without the new handgun legislation. So why would that be? Well, the people that live in New York City are younger, and higher age is associated with increased risk of mortality. So whether there was legislation or not, that mortality difference would still exist. Next slide. Diagnostic testing. So this next section is rather math intensive. And so I would just encourage you to revisit the slides and revisit the other review material as you go through all of these, because it can be a little intense. So just bear with me as we go through all of this math, because it is really important. Diagnostic testing and the screening calculations that we'll go over direct decision making for appropriate treatment or disease prognosis. And it's based on information that we know and gives us the probability or likelihood of disease, or the probability or likelihood of no disease. Next slide. So we need to think about diagnosis versus screening. And in diagnosis, these are some simple parameters to help you differentiate. In diagnosis, a patient presents with symptoms, and the physician or clinician may suspect a particular disease. There are usually a multitude of symptoms that the patient presents with, and clinical decision-making takes place to move forward. With screening, testing is usually conducted independent of symptoms, and I'll talk a little bit about the natural history of disease. You're usually looking at one variable, like blood pressure or glucose. And we're trying to classify individuals with their respect to the likelihood of having or getting a particular disease. Next slide. So screening involves some value judgments that you need to consider. What's the risk of dying from a disease? What are the benefits of screening? What are the harms of screening? What is the impact of a false positive? Do you have to consider overdiagnosis of a condition? Are there costs incurred? Is there discomfort, either physical or emotional, and embarrassment of being labeled with a certain disease if you really don't have it? And that considers the values and preferences of the population. Next slide. So the World Health Organization has some recommendations for screening and policy making. So the condition that you're screening for should be important. There should be a high prevalence, and it should be considered severe. There should be a treatment, because imagine if you screened for a disease and found people that had the disease and there was no treatment, what would you do? There should be facilities for diagnosis and treatment. So if you're going to do a screening, you need to be able to send people who test positive somewhere for confirmation or treatment. There should be a latent stage for the disease, which means there's a stage where it's asymptomatic. And there should be a reliable test or exam for the condition. Next slide. Also, the test should be acceptable to the population. If a screening test involves surgery, that's not very acceptable. But maybe if it's a finger stick or a blood pressure, that's more acceptable. The natural history of the disease needs to be adequately understood so you know where in the disease process you need to do the screening. There should be a policy on who to treat, and the cost of finding a case should be economically balanced in relation to a medical expenditure as a whole. So if you're spending a lot of money on case finding, is that money well spent, given the potential costs of that case finding? And it's a continuous process, not just a one-time thing. So you're constantly screening for cases of a disease as a part of routine care. Next slide. So when we look at the accuracy of a diagnostic test, we go back to the 2x2 table. And so on the right of your slide is the 2x2 table that we use to look at the accuracy of all common tests. And so while it's the 2x2 table that we're used to, the labels are a little bit different. So you'll see down the left side, we're looking at the characteristics of the test. And across the top, we're looking at the absence or presence of disease. And most of the time, the 2x2 tables will be set up this way. Next slide. So when we're looking at diagnostic test performance, there are several methods for measuring the performance of a test that are linked to the characteristics of the test and the population. Can you click one more time? You can go ahead and click through all of those. So these are the calculations that we do to look at diagnostic test performance. The first thing that we need to know is the prevalence of the disease. And so if you look at the 2x2 table, you can see that the orientation of the 2x2 table is, I don't know if you can see my mouse, but we're looking at the true positives and the false positives across the top two cells, false negatives and true negatives in the bottom two cells. And when you add all of the true positives along with the when you look at the true positives along with the false negatives, these are all the people with the disease, and divide them by the total population, you get the prevalence of disease. And as Dr. Wilson said, these are the people who have the disease at a certain point in time. So true positives plus false negatives divided by the total population gives you the prevalence of the condition. The sensitivity is more about the disease. So the sensitivity assesses the true positives in the population, or in other words, those who have the disease who will test positive. So we're looking at the people who have the disease and those who test positive. So those are the true positives, and that represents the sensitivity. The specificity, on the other hand, looks at the true negatives. And among those who, this is telling us among those who don't have the disease, how many will test negative. So sensitivity and specificity are all about the disease, and we're looking at the columns here in the 2x2 table. When we want to look at the characteristics of the test, we're looking left to right. So the positive predictive value looks at the likelihood of those who test positive actually having the disease, and the negative predictive value tells us in those who test negative who truly does not have the disease. And there are trade-offs between all of these tests. Next slide. We're going to go through an example here. So in this particular case, we're looking at a case of pneumocystis pneumonia. That is our disease. So we have people, the disease is listed across the top. So people who have pneumonia and people who don't have pneumonia. And then looking at the test for pneumonia, across left to right are the number of people who had a positive test, and left to right the number of people who had a negative test. And so you'll be able to calculate the prevalence, sensitivity, specificity, positive predictive value, and negative predictive value given these numbers. Next slide. And so, can you click again? So in this particular case, if we want to look at the prevalence, and also just know that these are expressed as decimals, but you will often see them expressed as percentages. So just multiplying by 100 gives you the percentage. But if we want to know the prevalence of disease, we're looking at, when we look at our formula, we have all of the people with the disease, so 31 people, divided by the total population, giving, which is 184, giving us a prevalence of 17%. And so as you go through each of these calculations, and I would encourage you to try all of these, given the formula on the previous page, you'll come up with these answers. And so what do they mean? So if we look at the 68% here, the sensitivity, that means that the probability of correctly identifying people with pneumonia is 68%. The specificity is 97%, meaning that the probability of correctly classifying people without the disease is 97%. The positive predictive value tells us that of the positive tests who really has pneumonia, so that's the positive predictive value, whereas the negative predictive value tells us of those with negative results, what proportion do not have pneumonia. In this case, it's 93%. So I would just encourage you to try those calculations on your own. And while the exam doesn't have calculations on it, it's really important for you to understand what these terms mean. Next slide. So what is the relationship between sensitivity and specificity? So lowering the criterion of positivity results increases sensitivity, which means you'll detect more cases, but that's at the expense of decreased specificity. If you make the criterion of positivity more stringent, it increases specificity, but at the expense of decreased sensitivity. So the goal is to have both high sensitivity and high specificity, but it's often not possible or feasible depending on the condition and the test. And if you have continuous data, there's always a decision about what cut point makes sense, and weighing the consequences of leaving cases undetected, false negatives, against erroneously classifying healthy people as diseased or false positives. And again, that all depends on the burden of the additional testing that might be needed. Next. So sensitivity should be increased when the penalty associated with missing a case is high. So if the disease can spread rapidly, like a highly infectious disease, or subsequent diagnostic evaluations are really minimal. So if someone can be followed up at a low cost and low risk, why not have a highly sensitive test? The specificity should be increased when costs or risks associated with further diagnostic testing are substantial. So you want to minimize false positive. So for example, if you screen positive, you have to have a biopsy. So that's something that you want to be careful of. Next slide. So what are the benefits of detecting disease early through screening? So it depends on if indeed the disease can be detected early. So something that is a highly contagious with a high case fatality rate, screening may not make any sense. You need to know the sensitivity and specificity of the test. What is the positive predictive value? How serious is the problem of a false positive? What is the cost of early detection? And that's not just monetary, it's also the emotional impact. Can subjects be harmed by screening? And that's also a physical and emotional decision. And is there a benefit from early detection by screening? For example, will you actually decrease mortality if it's early, if the disease is detected early? Next slide. So in order to answer some of these questions, it's really important to understand the natural history of disease. Any disease will progress from the healthy state to disease development, symptoms, care-seeking behavior, diagnosis, and ultimately some treatment or outcome. In this particular figure, the outcome is either dead or alive. The natural history of disease, as you can imagine, is quite variable, with some diseases developing slowly, like diabetes or some cancers, while others develop really quickly, like some infectious diseases. So whether or not a screening test is conducted and when it is conducted is highly dependent on the natural history of the disease. Next slide. So there are two phases of disease, and you can see in red at the bottom of the slide, there's the preclinical phase and the clinical phase. The preclinical phase, in most cases, people are asymptomatic. The disease is there, but the person is not experiencing symptoms. In the clinical phase, there are symptoms, ultimately diagnosis and treatment, and ultimately the outcome. So ideally, a screening test is introduced in the preclinical phase prior to symptoms and diagnosis. And ideally, we hope that early detection leads to early treatment and ultimately better outcomes. But unfortunately, this is not always the case. Next slide. So our final checkpoint today is for you to determine what formula or what is the formula given here represent. So true positives plus false negatives divided by the total sample size is what? And there will be a poll that comes up. Okay, I think we probably have all of our answers by now. So 15% of you said false positive, 42% said prevalence, 8% said accuracy, and 36% said sensitivity. Those of you who said prevalence have the right answer. If you didn't get the right answer, please go ahead and revisit the formulas that were presented at the beginning of the diagnostic testing examples. And so, Erin, I think we have all of our material presented and would be happy to take some questions.
Great, thank you so much. We have had a few questions submitted so far, so I'll go ahead and read a couple of those. And then if you have any other questions, please, if you click on the little orange arrow, that will open up your control panel, and then you'll be able to see your question input, and you can type your questions in there. So please feel free to submit some questions, and I will go ahead and read one that was submitted. When we were talking about case controls, it said, somebody asked for clarification. She said, so case controls work, quote unquote, backwards. Can you elaborate on that?
That's a good way to think about it. Yes, case control studies are typically considered retrospective. So you start with individuals who have your condition of interest, which are your cases. You find individuals that are hopefully fairly similar to your cases, with the exception that they don't have the condition of interest. And then you look back to see whether or not they were exposed to your exposure of interest. So yes, that's a good way to look at it.
Great. Okay, so now we have a sensitivity question. Can you clarify if I have this correct? Increasing sensitivity or minimizing false negatives is generally good for screening tests, whereas increasing specificity, minimizing false positives is generally good for diagnostic tests.
Let me write that down so I make sure that I answer that correctly.
Can you read it again, Erin?
Yeah,
please?
can you read it again?
Yes, let's see. Increasing sensitivity, quote, in parentheses, minimizing false negatives, is generally good for screening tests, whereas increasing specificity or minimizing false positives is generally good for diagnostic tests.
You know, I hate to say this, but it really depends. It depends on the disease and it depends on the testing. Because I can think of diseases where you want to minimize false negatives, where the disease has a high case fatality rate, so you know, a highly contagious infectious disease that is likely fatal. You really want to make sure that you're finding the true positives and increasing the sensitivity. For specificity, if you're going to tell someone that they're negative, you want to make sure there's no consequence if you make a mistake. So it really just depends on the disease. I don't think it's as black and white as what the question states. It really depends.
Okay, great. A research design question. Can you talk a little bit more about, quote unquote, pilot testing's role or value when designing questionnaires?
Pilot testing is very valuable because if you design a questionnaire and you administer the questionnaire to 100 people, 200 people, but there is a flaw in your questionnaire, you can't go back and undo that. So that's a great thing about pilot testing. You get the opportunity to design it, to pilot it with a handful of people, so you really haven't lost much time, energy, effort, or money. So yeah, there's definitely a benefit, a huge benefit to pilot testing before you implement anything on a grand scale.
Agreed.
Great. Can you provide another example of confounding?
Sure. So we're going to talk. You can go ahead.
I have one that I use a lot because my area is maternal and child health. So one example of a confounder from maternal and child health perspective. There's been some research that has shown that women who consume coffee may be at greater risk for delivering an infant early or delivering a preterm infant. So looking at that data, you would want to look at, okay, so what is the mechanism that causes caffeine to lead to preterm labor? But it was actually found that it wasn't necessarily the caffeine, it was the fact that the majority of women who were coffee consumers also smoked cigarettes. And so cigarettes were the hidden confounder, because cigarettes were actually what was driving the women to deliver early, but they were also related to the coffee consumption. So cigarettes were confounding the relationship between coffee consumption and preterm delivery.
Great, thank you. Can you review again why disease must be rare in order to approximate to RR?
Okay, so this is an algebra question, but essentially it has to be rare because when you look at that 2x2 table, we have to look at A plus B, which is the row of all individuals who are exposed. And then we also have to look at our row of all individuals who are unexposed. When the disease is rare, that A plus B is going to approximate just B, and then that C plus D is going to approximate just D. And so once you again work that algebra, you're going to find that when you simplify that, then your OR will approximate your RR. It's unfortunately more than what we can go into without having a marker and a whiteboard and some algebra in front of us. It's a good rule to know for a test question.
Great. Can you give some examples of questions that we might see pertaining to sensitivity and specificity? It's hard to think about what will be asked since there are no calculations on the exam.
So I honestly, I took the CPH exam in 2016, and that's the last time I've seen questions because we are not allowed to see the questions. And so in general terms, I can tell you that I would want you to understand the importance of diagnostic testing and whether sensitivity and specificity are about the disease or about the test. So as I stated before, sensitivity and specificity are more about the disease, the columns in the 2x2 table, whereas the positive predictive value and negative predictive value are more about the characteristics of the test. Erin, I don't know if you can add any insight into that, but I don't know what the questions are, so I can't do that.
Well, and I'll go over, I'll review the study resources we have available when we're done with the questions, but there are some practice questions that you can review for free, and then I'll also go over the ASPPH study guide that you can log into and see all different types of sample questions. So let's go ahead and cover a few more questions that have been submitted though. Can sensitivity and specificity both be high, or it works vice versa?
No, they can both be high, and actually that's the ideal that you want to go for, is that both sensitivity and specificity are high, so that the likelihood or the probability of getting a positive test if someone has a disease is high, and the likelihood of them not having the disease if the test is negative is high. So there are some trade-offs sometimes depending on the disease and the test, but ideally, you would like them both to be high.
Great. What does PPV and NPV mean?
Those are the positive predictive value and the negative predictive value. If you look on the very first slide that I went over, they're spelled out on the very first slide of the diagnostic testing slides.
Okay, great. Can you give an example for ecological fallacy?
So, for example, with the figure that I gave, it looked at 71 countries, I think it was prostate cancer mortality rate compared to the sugar consumption. And what the graph showed was a general trend that the higher the sugar consumption, the higher the rate of prostate cancer mortality. The ecological fallacy in that example is just to assume that if an individual consumes a lot of sugar, then they're at increased risk for prostate cancer mortality. So that's the ecological fallacy. You can't take something that you've learned from an ecological study looking at an entire group and apply it to just one individual within that group. Or you can't assume that everyone who died of cancer, prostate cancer, consumed a high amount of sugar.
Okay, great. Here's a follow-up question to the PPV and NPV. Sorry, what does it mean an example? What does PPV and NPV mean an example? Like PPV means all of the positive tests in blank.
Oh, so the positive predictive value tells us of those who test positive who has the disease. So if you're looking at the 2x2 table, you're looking across the rows. So in other words, the positive predictive value looks at who has the disease divided by everyone who tested positive for the disease. Similarly, with the negative predictive value, it tells us of those who test negative who does not have the disease. So in that particular case, you're looking at the true negatives divided by everyone who tested negative on the test. I hope that answers the question.
Great. Okay, do we need to know about attributable risk, and can you explain what it is?
I don't know if you need to know it or not, but attributable risk is the proportion of risk that is attributed to a certain risk factor, I believe. But I don't have that right in front of me, but we'll give you an answer in writing for sure.
Okay, great. Can you mention which study designs use the OR compared to those that use the RR?
So just about every study design except for the randomized control trial can use the OR. So the OR can be applied to the cross-sectional study, the cohort study, the case control study, of course, and the RR is primarily the cohort study.
You said that.
Did I say it backwards?
Yeah, so
the
RR can be used for the clinical randomized controlled trials, as I had stated in mine, but it can also be used for the cohort study. And so you think odds ratio being used for case control studies and cross-sectional studies.
Great, okay. It looks like that's all the questions that have been submitted. So is there anything else that you two want to discuss or go over? Actually, one was just submitted. Can you repeat that OR versus RR, please?
Yes. So if you're talking about the odds ratio and the relative risk as it pertains to study designs, if you think of if you're moving forward in time, that's the easiest way to remember this. If you're moving forward in time with a study, so you're starting at a particular time point and measuring out forward in time. So like a cohort study, you're looking forward in time. A randomized controlled trial, you're looking forward in time, and you can actually calculate incidence. That's where you can use the relative risk, because you can actually calculate risk. In a cross-sectional study and in a case control study, you're either looking at one point in time or looking back in time, and you can't calculate risk. Therefore, you calculate the odds ratio.
Okay, great. Thank you. Is there anything that you two wanted to kind of go over or talk about before I go over the different study resources available?
I can't think of anything. I'm looking for the attributable risk now. Hopefully I'll get that answer so I can verify that.
Okay. Well, I'll go ahead and go over the study resources once again. I talked about them a little bit prior to the presentation actually starting. And to just clarify the presentation, we've recorded this presentation, and then we're gonna take the presentation recording as well as the PowerPoint presentation, and we're gonna archive those on the NVPHE website. So if you go there now, you can see all the ones that have been done in the past, and then we will add this one as well as the ones that are coming up. So you'll have those available, and that should probably be, hopefully our IT folks can get that up by Friday, if not, then early next week. And there was another question, general question about regarding math on the exam. There is not any actual math on the exam. You won't need a calculator or what have you, but you will need to recognize different models, different theories, different definitions, but you won't need to be doing any actual calculations per se. So let's see here.
Erin, can I address attributable? So the attributable risk is what I said it is. It's the excess proportion of disease that's present. And that's the proportion that would be eliminated if the risk factor or exposure was eliminated. So my memory served me once in a while.
There was one other question that was just submitted. What is the difference between RCT and case control study?
So if you look at the figure that we provided that has all of the study designs on it, you know, when you get the slides, you'll see there's a figure. And the randomized controlled trial is where the investigator can actually assign or implement an intervention or an exposure. And so the randomized controlled trial, you know, it can be randomized or non-randomized, but the biggest difference is the investigator is controlling the exposure, okay? In the case control study, which is one of our observational studies, the investigator cannot control the exposure. So in a case control study, we're looking at people who are have the disease or not, and looking back in time at the exposure. So it's more of a natural history of exposure as opposed to actually introducing the exposure as you do in an experimental study or the randomized controlled trial.
Great, okay. It looks like there's no other questions on that. So I will go back up to the study resources and we can go over these one more time. So the first resource we have available is that content outline we discussed, and that's going to go over, it's available on the NBPHE website. All of this stuff is linked on that website, and that's going to go over the 10 different content areas. And then within each of these content areas, there's going to be specific job tasks that outline and define the different things within each of these areas. So for example, in law and ethics, it's going to talk about recognizing various policies internationally and nationally on what governs and controls the different political ramifications of public health. In public health biology and human disease risk, there's different things about infectious disease and non-infectious disease, and it'll kind of outline that kind of information. So in each of these, there will be various job tasks that you can look at to understand what goes into each of these areas. Let's see here. Also on the NBPHE website, there's going to be free sample questions. Again, these are going to be static questions. They are not going to change, but you can walk through that and get just a sample of the type of questions that are asked. Again, they're going to be single best answer, multiple choice questions. You won't be asked for open-ended answers or any essay questions or that sort. Practice exams. Once you take the practice exams, you're going to get a detailed report with the results. So it's a good way to kind of see how prepared you feel and then what else you need to focus on and identify those areas that you do need to focus on. Speaking of, once you identify those areas, you may want to tune into the upcoming webinars, lecture and Q&A. And I had a lot of folks ask me in the chat box if for the next one, if we can go ahead and post the PowerPoint presentation so that you can follow along and take notes. And certainly, we can certainly do that. This is the first one we've done in a while. So really any input that you guys have to make it better and more useful for you, we are happy to do. So we will go ahead and for the next one, we will have that PowerPoint posted prior to the presentation so you can follow along and take notes as you go. And then all of these are able to register via the NBPHE website. And let's see here. Then we have the CPH study guide, and this is going to be available through ASPPH. It is cphstudyguide.aspph.org. It is $49.95, and this is going to be that interactive practice exam study guide. It's going to have all of the content from the job task analysis. It's not going to be a textbook per se. It's going to be more interactive questions. So you go through practice exams, and then for each of those practice exams, it'll have a detailed explanation of the questions, what you got right, what you got wrong. It's going to have resources and links that you can click on, and some of those questions are going to have a video explanation from subject matter experts as well. And then let's see here. The APHA Press Study Guide. Now, this was written by our fabulous faculty at the University of South Florida College of Public Health. It was written independently. These are folks that South Florida was one of our earlier adapters of the CPH, and all of their faculty, or most of their faculty, are all certified in public health, and their students are required to take the exam. So it behooves them to know what they're talking about. So all of our subject matter experts that do the APHA Leadership Institute every year are from South Florida, and they have been kind enough to take their expertise and to put it in a textbook. So if you want a comprehensive read about it, learn about it, similar to the content that was presented today, but in a textbook form, you want to purchase this book. And you do so, you just go to APHA Press. It's $41.95 for APHA members and $51.95 for non-members. And you can also get the ebook or the print version for that, so whichever you feel most comfortable with. So if we don't have any further questions, I'm thinking we're about done today. Do we have anything from our fabulous presenters on anything you want to cover or talk about prior to signing off?
No, not at this time. We just appreciate the opportunity to conduct this review webinar, and we wish all the attendees the best of luck on their exams.
Wonderful. Thank you so much, and thank you for joining us today. We will go ahead and if there's any follow-up information or questions that we did not get a chance to answer, we have everyone's email that participated today, and we will follow up with some information for you all. And if you have any questions, you can always reach me. I'm Erin Williams, ewilliams@asppph.org. Or if you have questions for our presenters, I can get you in touch with them as well. So thank you very much. Thank you to our presenters, and thank you for our attendees. Have a great day, and we hope to see you next time.